Dear student, in this video, we are going to discuss about the mechanics of breathing. At the end of this session, you will be able to list the muscles of inspiration and expiration and give their mechanism of action. We'll be able to explain the alveolar and intrapleural pressure changes during quiet inspiration and expiration. You will be able to describe sequences of events during inspiration and expiration. As we all know, there are two phases of respiration. One is inspiration, another is expiration. Normally, during quiet breathing, inspiration is an active process which occurs due to contraction of the inspiratory muscles, whereas the normal quiet expiration is a passive phenomena that occurs due to elastic recoiling of the lungs. Now we want to know what are the important inspiratory muscles which take part in the active part of the inspiration. Inspiration is an active process. Now the primary muscles of inspirations are mainly two. One is the diaphragm, another is the external intercostal muscles. So first come to the diaphragm. So diaphragm is the main muscle of inspiration. It is a skeletal muscle. Inflation of the lungs is caused primarily by the contraction of the diaphragm. Now, diaphragm is dome shaped and it is attached to the lower six ribs and the xiphoid process of the sternum. Thus, when it contracts, the dome is flattened and abdominal contents are pushed downward. So, you can see here. So, when the diaphragm contracts, the dome is flattened and abdominal contents are pushed downwards so that the thoracic cavity enlarges in the vertical direction. So what is the function of the diaphragm? When it contracts, the vertical diameter of the thoracic cage increases. In addition to that, contraction of diaphragm also pushes the rib cage outward that enlarges the thoracic cavity in its anteroposterior diameter. So what is the function of diaphragm? To increase the vertical diameter of the thoracic cage and also to increase the anteroposterior diameter of the thoracic cage. Now during quiet breathing, the downward movement of the diaphragm, it is around 1 to 2 centimeter. However, during forced inspiration, descent of diaphragm occurs at about 10 to 12 centimeter, so that greatly increases the thoracic volume. Now, the important point is that inspiration is significantly compromised in certain conditions. First is, we know that diaphragm is innervated by phrenic nerves, that is C3 to C5 cervical roots. Each lateral half of the diameter is innervated by phrenic nerves on that side. Lesion of the phrenic nerve results in paralysis of the diaphragm. It should be noted that when a phrenic nerve is damaged, the portion of the diaphragm on the side moves up rather than it coming down during inspiration. This grossly impairs the ventilation. So one of the important cause that significantly compromises the inspiration is the diaphragmatic palsy. Second is the moderate obesity, pregnancy, especially during the third trimester, and the tight clothing around the thoracic and abdominal walls. It will also decrease the expansion of the lungs and it will prevent the lung to enlarge the thoracic cavity, and that will compromise the inspiration. Now come to the next muscle, that is the external intercostal muscles. External intercostal muscles are present obliquely between the ribs and the direction is forward, downward and medially. So when these muscles they contract, there will be two types of movement. So obviously it will raise the rib cage adequately. Now there are two types of movement. One is the bucket handle movement. On the right hand side, you can see that it is a bucket handle movement. The second to 10th ribs rotate upward and outward by this movement, similar to the movement of the handle of a bucket. Okay, so when it is moving in this direction, so what will happen? The transverse diameter of the thoracic cavity, it will be increased. Okay, so this is about the bucket handle movement due to contraction of external intercostal muscle. Due to contraction of the external intercostal muscle, another type of movement may occur, that is a pump handle movement. The upper four ribs rotate the sternum in upward and outward direction by the movement of this pump handle movement. You can see on the left hand side, it is moving the sternum and the thoracic cage, it is moving outward, okay, upward and outward. So this will increase the anteroposterior diameter of the thoracic cage. So bucket handle movement will increase the transverse diameter, and whereas the pump handle movement will increase the anteroposterior diameter. So we can see that when the inspiratory muscles are contracting, so when the diaphragm is contracting, the vertical and anteroposterior diameters are increased. When the external intercostal muscles are contracting, due to bucket handle movement, the transverse diameter is increased. Due to pump handle movement, the anteroposterior diameter is increased. So as a result of that, we can say that there is increase in the diameter of the thoracic cage. Now come to the some accessory muscles of inspiration. Now accessory muscles, they assist in the forced inspiration. I emphasize the term forced. Normally when we are taking the quiet breathing, these muscles are not doing their activity. During forced inspiration, these muscles will help. For examples, the scalene muscles, the scalene muscles of the neck, they are inserted to the upper two ribs. They are brought into play during deep breathing. They elevate the upper part of the rib cage. Then sternocleidomastoid muscles, they are inserted into the upper two ribs and top of the sternum. These muscles lift the sternum outward and elevate the rib cage. They contribute actually the pump handle movement. Then also we have the neck and back muscles. Contraction of neck and back muscles during forced respiration increase the thoracic volume in two ways. Firstly, they elevate the pectoral girdle, that increases the cross-sectional area of the thorax. Secondly, they extend the back, that increases the vertical length of the thorax. Now, muscles of the upper respiratory tract like ali, nasi, levator pili, cheek muscles, they also can contribute to they can act as the accessory inspiratory muscles. Now, when inspiration ends, the inspiratory muscles relax. Okay, the rib cage drops and the thoracic volume decreases. There will be elastic recoiling of lungs, will be now unopposed, and all of these will help in the deflation of lung and the expiration. So we can say that primarily the expiration is a passive process. No muscles actually are required for it. But there are certain accessory muscles which help in the expiration, but that is in forced expiration. What are those muscles? It may be the abdominal muscles, muscles of the abdominal wall, like the internal oblique, external oblique, transverse and abdominis, and contraction of this muscle increases the intra-abdominal pressure and pushes the diaphragm upward into the chest cavity. Okay, so that will help in the exhalation. In addition to that, internal intercostal muscles pull the rib cage downward, decrease the thoracic volume both in anteroposterior and transverse diameter. So it will also help, will act as the accessory expiratory muscles. Neck and back muscles that lower the pectoral girdle, decrease the cross-sectional area, they can also act as the accessory expiratory muscles. Now the physiological significance, it has got two. One is during forced inspiration, accessory muscles are used to increase the lung volume rather than to overcome the resistance of airflow. Whereas during forced expiration, accessory muscles are used mainly to overcome the resistance to airflow. Okay, so why do we take the forced inspiration or expiration? Because there is some obstruction. I need the extra help. But during forced inspiration, accessory muscles, they are used to increase the lung volume, but not to overcome the resistance. Whereas during forced expiration, accessory muscles are used to overcome the resistance of the airflow. And the strength of the expiratory muscles, it is important in endurance training, that is running. So therefore, for long distance runner, physical exercises are advocated to strengthen their abdominal and chest muscles as a part of their training program. Okay, now quiet expiration is passive. However, exception to this is the individual suffering from lung diseases like bronchial asthma, in which airway resistance is high, so they require active participation of these expiratory muscles in normal expiration. So, what are the physiological three important physiological significance here? During forced inspiration, accessory muscles are helping, but helping for what? To increase the lung volume, not against the resistance. During forced expiration, accessory muscles are used to overcome the resistance. And during endurance training, these abdominal muscles they are strengthened. And the third point is quiet expiration is passive, but however, in bronchial asthma, individuals suffering from this disease, the airway resistance is very high. That's why the active participation of expiratory muscles are important. We know that expiratory muscles they are acting accessory expiratory muscles acting against the resistance of the airflow. So asthmatic patient their accessory expiratory muscles are very much active in order to reduce the resistance to airflow. So this is about the muscles in the inspiration and expiration. Then come to the pressures in the thoracic cavity. Here we will discuss mainly three pressure. One is the intrapleural pressure, alveolar pressure and transmural or the transpulmonary pressure across the lung. Now, first is the intrapleural pressure. So, what is the intrapleural space? It is the space between the two layers of pleura. We know that pleura has got two layers. One that is the visceral pleura which is attached with the lung. Another is the parietal pleura that is attached with the chest wall. So, the space in between this visceral pleura and the parietal pleura, this blue area is the intrapleural space. And the pressure in this space is the intrapleural pressure. Okay, so normally this intrapleural pressure is subatmospheric or negative. Okay, so this is the intrapleural pressure and it is negative. What is the value of this intrapleural pressure? It is around minus 2.5 to minus 4 millimeter of mercury. So if we take the atmospheric pressure 0, so anything below 0 is minus. So minus 2.5 to minus 4 millimeter of mercury or minus 5 centimeter of water. So one is in the mercury, another is a millimeter of mercury, another is in the centimeter of water, H2O. So these are the intrapleural pressure. Okay, normal value of it is minus say minus 3 millimeter of mercury or minus 5 centimeter of H2O. Now what about the intra-alveolar pressure? So we know that inside the lung we have the alveoli. So alveolar pressure, when there is no airflow, so obviously its pressure is equal to the atmospheric pressure, that is 760 millimeter of mercury. So it is, we can take it as 0. So intra-alveolar pressure is 0 when there is no airflow. Now what about the intrapleural pressure? It is below the atmospheric pressure, that is minus 4 millimeter of mercury. So it is 756 millimeter of mercury. If the atmospheric pressure is 760, so it is below 4, so minus that is 756 millimeter of mercury, or we will call it minus 4 millimeter of mercury. Okay, now what about the transpulmonary pressure? So intraalveolar pressure, it is the pressure inside the lung. The alveoli is inside the lung. Intrapleural pressure, it is outside the lung. Now what is the transpulmonary pressure? It is the pressure difference between inside and the outside the lung. So inside we have the alveolar pressure, it is 0, that is at when there is no airflow, it is equal to the atmospheric pressure, so 0, minus, that is intrapleural pressure, that is minus 3 millimeter of mercury. So the transpulmonary pressure is a positive pressure, that is plus 3 millimeter of mercury. Okay, so intraalveolar pressure is 0, intrapleural pressure is subatmospheric -3. So 0 minus 3 is plus 3 millimeter of mercury. And what is the importance of this transpulmonary pressure? Transpulmonary pressure is the pressure that acts against the elastic recoiling of the lung. It tries to expand the lung or the alveoli. So here we can see this. Now the question is why the intrapleural pressure it is always negative. Okay, so one point we know that the parietal pleura which is attached with the thoracic wall, and the thoracic wall has a tendency to move outward, whereas the visceral pleura is attached with the lung, and the lung has the elastic recoiling power, so it will try to move inward. So the parietal pleura is trying to move outward along with the chest wall. The visceral pleura is trying to move inward along with the lung. So these two equal and opposing force is actually creating a negative pressure or subatmospheric pressure in the intrapleural space. So the pleural space is a relative vacuum. The lungs have the tendency to collapse and the chest wall has the tendency to expand. Therefore, the elastic recoil effects of lung and the chest wall are exerted equally but in opposite direction. This is the reason why the intrapleural pressure it is subatmospheric or negative. Now come to the mechanics of inspiration. Here you can see here that how it is happening. The step number 1 is the contraction of the diaphragm and the external intercostal muscle. What will happen? We know that all these diameters, vertical diameter, transverse diameter and the anteroposterior diameters, it will be increased. So the diameter of the thoracic cage is increased. So the visceral pleura, that is the parietal pleura along with the thoracic cage, it is moving outward, whereas the visceral pleura with the lung elastic recoiling, it is moving inward. As a result of that, the volume on the intrapleural space, it is increasing. Obviously we can say that when the thoracic cage with the parietal pleura is moving outward and the visceral pleura with the lung recoils inside, so the space in between, there will be increase in the volume of the intrapleural space, and we know that volume is inversely proportional to pressure. So intrapleural pressure will become more negative. It was subatmospheric -4 millimeter of mercury. It will further become more negative, that is it will go up to -6 millimeter of mercury during normal breathing or -8 centimeter of H2O. And during forced expiration, it can be as low as -30 millimeter of mercury. Okay, so the intrapleural pressure will become more negative as the thoracic cage with the parietal pleura is moving outside and the visceral pleura is moving inside, and the intrapleural space is volume is increased, pressure will be decreased and more negative. As a result of that, when initially the transpulmonary pressure was 0 -3, so +3. So when during quiet expiration it will become 0 -6, so +6. During forced expiration it will become 0 -30, so +30. So result is the transpulmonary pressure will become more positive. So step number 1 is contraction of muscles. Step number 2 is the expansion of thoracic cage. Step number 3 is intrapleural pressure will become more negative. Step number 5 is transpulmonary pressure will be more positive, and transpulmonary pressure is the pressure that acts against the elastic recoiling, so the alveolar volume will be increased. Now alveoli will be more volume, so if the alveoli volume is more, its pressure is less than what? Initially it was 0, that is atmospheric pressure. So it is below atmospheric pressure, means from the atmosphere the air will enter into the alveoli, and this is nothing but your inspiration. So these are the sequences of events during inspiration. Now what about the expiration? Relaxation, it is a passive process. Relaxation of inspiratory muscles, dropping of the rib cage, intrapleural pressure become less negative, so the transpulmonary pressure will decrease, deflation of the lung and decrease in the alveolar diameter. Alveolar pressure becomes greater than the atmospheric pressure. Air will be pushed out of the lungs and the airflow will be outside the lung. So that is your actually the expiration. So these are the process of expirations. Okay, so inspiration and expiration, we know that the thoracic cage. Now come to the pressure changes that we will describe here in a graphical pattern. First we will see about the intrapleural pressure. So from this graph you can say that, see that it is starting from -3. Okay, so along the x-axis here we have plotted the pressure, along the y-axis we have plotted the time. Time is further subdivided into two parts, one is the inspiration, another is the expiration. So inspiration you can say minus, from -3 the intrapleural pressure, the below one that is intrapleural pressure, from -3 it is going down and it is reaching the -6 at the end of inspiration, and after that it will be restored. The one point is that it is not perfectly u-shaped because of the viscous resistance, so it is after certain time, so at the end of expiration it is original value will be restored. Now the topmost one, okay, the topmost one is the change of the intraalveolar pressure. So intraalveolar pressure at the onset of inspiration, when there is no airflow, it is 0, that is atmospheric. Now the thoracic cage is expanded and everything happened, so the intrapleural pressure will become negative. How much? So from 0 to it will go to -1 at the half of the inspiration. Then the air entry will take place, and when the air entry is finished, then it will be restored and it will again become 0 atmospheric pressure, so there will be no further airflow. Then the expiration will start, so it will from 0 it will become positive, so +1, and after that at the mid of this expiration, and after that when the air will be pushed out of the lung, it will again be restored to 0, so there is no airflow. So this is about your alveolar and intrapleural pressure relationship during quiet inspiration and expiration. So intrapleural pressure is negative in both the phases of respiration, and alveolar pressure is negative during inspiration and positive during expiration. Thank you.